So why is this test not used by oncologists in the United States?
Well, there's probably many reasons, but there are some similar tests being looked at and trying to do a similar type test, but most of them are using the test on tumors rather than blood, because there's unique things you need to do in a certain way. From what I understand, you need to do this so you're able to use those cells and find enough of the cells in the blood to make it worthwhile to be able to grow them and so forth. But to make a long story short, there are people looking at similar things, but they're trying to do it off of biopsies of solid tumors, and we find it best overall to use the blood, especially anytime that we can, to use the blood. So a lot of the oncologists have not heard of it, and they're guided by what they're told by the associations and by the medical boards, what they can use, what they can't use. So a lot of them have not ventured into using this point, but I can say as of this past weekend, there is a much greater interest than I realized of the oncologists aware of this on their own. And if you probably had them in a private meeting with no cameras, no recorders, you would probably be kind of awed at what they are willing to tell you. So I would say that a lot of them are looking for better ways to help the patient, but they're not close yet to doing any of this.
Interesting. Dr. Jans, your thoughts?
Well, I would like to standing as a third party and see it from two major perspectives. Most of the oncologists, no matter they are clinical or medical oncologists, they have been trained under the mentality of evidence-based medicine, which means that they have to run under statistic preview large trials, which the best outcome with the best statistics will be applicable to all patients. This is not the case, because here we are talking about personalized medicine. So each person is individual, and you cannot put a treatment plan according to statistics to an individual, because it may be outside the statistic preview or the statistic prediction. That's the first. And the second is that most of the medical oncologists are very occupied by their daily work, so it may be very difficult for them to look by their own, the recent development, the articles, etc. So it means that they continue to be trained and be continuously educated, but what they actually given to them by their association or by pharmaceutical industry, etc. Which makes them to be much more rigid to make choices for each individual. On the other hand, now that for different reasons evidence-based medicine has many problems to deal with this plurality and these dynamic features of cancer, we notice that slowly we have a shift of interest from the medical association, from the pharmaceutical industry, to more personalized treatment. So we have a hope that slowly we will have a focus to personalized medicine. This is where all these tests comes to a point which they become very interesting to oncologists. But we are not there yet. We are in process, but we haven't reached that point. So what happens in reality is that the test that they are already existed, or the test approach, either they use as the primary material to obtain all this information, the primary tumor, which if we see what happens in clinical reality, patients actually die from metastasis and not from the primary tumor, just because the metastatic points doesn't behave the same way like the primary tumor. And this is what reveals the dynamic features of cancer. So that's why we need to obtain all the necessary data from these cells, which they are going to generate the metastases. This is the reason why the circulating tumor cells and the cancer stem cells become very favorable and becoming the point of interest of the research community. So this is the one point. The second and the most difficult part is how you are going to obtain this entity of circulating tumor cells. Again, there are several approaches, and simply what differs our methodology from the others is that since the entity of circulating tumor cells and cancer stem cells is again non-homogeneous, is heterogeneous again, if you try to pick them out by basing your method on one or two markers or antigens, you may lose very important subpopulation of these cells. We preferred and we conclude that what we call negative selection is the best method to subtract all the unwanted cells, and whatever remains include all the heterogeneous population of circulating tumor cells. And this makes us be a little bit better than the rest. And then the rest process is straightforward. Everyone uses it. And simply since the target population is much more accurate, then the results become much more accurate, then the clinician has more accurate information to utilize in clinical practice. And this is actually justified by the clinical outcome when patients are treated according or based to that information.